Greetings and welcome to everyone. I'm David Hunt, Medical Director for Patient Safety in the Office of the Assistant Secretary for Technology Policy, also known as ASTP and formerly ONC. I'd like to welcome you all to this National Action Alliance for Patient and Workforce Safety webinar. This is our first webinar of 2025 and it's a real jewel. We'll be discussing the recently updated SAFER guides. Next slide. Before we start, I want you to know that this webinar is being recorded and will be available later on the National Action Alliance website. To engage with us and ask questions, please use the chat feature at the bottom of the toolbar of your screen. And also note that closed captioning for this event is also available through that toolbar. Next slide. We'd like to thank all the health systems who have conveyed a commitment to the 5 aims of the National Action Alliance. For those of you in systems that haven't yet formalized your commitment, we encourage you to have an executive leader lean into this opportunity by sending an email to National Action Alliance at hhs.gov. That's all one word, National Action Alliance at hhs.gov. Next slide. Now, here we can see a bit of a broad outline of our event today, in which we'll be joined by the primary author editors of the SAFER guides, Dean Sittig and Hardeep Singh. Dr. Singh will give you an overview of how important it is to proactively work to optimize the safety and the safe use of health IT with the guides. And Dr. Sittig will discuss the newly released 2025 guides and the process they use to update them. And finally, we are incredibly grateful that we'll be joined by Dr. Sengstack to highlight the practical considerations in using the guides. Next slide. Throughout, as you listen, I hope you'll be able to comfortably answer these following questions. What are the SAFER guides? Why are they needed? And while we all know that planning for patient safety is important, the execution of those plans is absolutely critical. So I'll ask that you actively consider how your organization can use these guides to improve patient safety. Next slide. Finally, note that throughout, we'll ask you to share your questions and concerns about using the SAFER guides. Next slide. So let's dive in with our first speaker, Dr. Hardeep Singh, Professor of Medicine at the DeBakey VA Medical Center and the Baylor College of Medicine in Houston, Texas. As a prolific safety researcher and author, Hardeep has been at the forefront of many national and international patient safety initiatives. He's received several prestigious awards for his pioneering work, including the Presidential Early Career Award for Scientists and Engineers, and in 2021, he was the John Eisenberg Patient Safety and Quality Award winner for Individual Lifetime Achievement. So I'd like you all to give a warm virtual welcome to Hardeep Singh. Hardeep?
Thank you, David, and welcome everybody, and greetings from snowy Houston. So I'm going to try to answer the question that David posed. Why are SAFER guides needed? There are several types of health IT safety concerns that have emerged over the last few decades, such as software malfunctions. We've had order entry errors. We've had workaround issues, unsafe workarounds. We've entered data into the wrong patient's chart. We've often had problems following up on critical information, which sometimes gets lost in the middle of a busy electronic health record. We've had interface issues where there is lack of transmission of data from one point to the other. And of course, everybody can relate to many of the cognitive issues that result from information overload because of the electronic health record. Let's go to the next slide. Now, all of these health IT safety concerns can lead to patient harm. So we've seen all of these come up. We've had medication errors and related harm. We've had delays in treatment and incorrect treatments. We've had lost referrals. There's one area that I study is missed test results follow-up, and we've seen how patients can get delayed diagnosis of cancer because their test result was not followed up on a timely basis because it was lost in the electronic health record. We've had instances of patient misidentification. If you can go back to the last slide, thank you. We've had instances of patient misidentification, And also we've had instances where preventive screenings have been missed because of this information getting buried. Next slide, please. Okay, so what we've tried to conceptualize over the last few decades is how do you define health information technology-related safety, and specifically EHR-related safety. So imagine electronic health records were believed to be beneficial for patient safety, but I just showed you a bunch of safety concerns that have emerged over the last few years because of the electronic health record. So what we've tried to do is to define what is EHR-related safety, and we've come up with these three domains which are a bit overlapping. The first domain is the technology has to be safe. So these are events that happen because of either a software glitch or software malfunction or a bug. We've had instances where 900 patients in UK were given Viagra instead of Wellbutrin because of a computer glitch. And the second domain is that of using electronic health records. So you may have good technology, we may have the best electronic health record in the world, but as humans, we need to also be able to use them safely and correctly. So anytime there's an inappropriate or unsafe use of technology, that falls in the second domain, which is using EHRs. The third domain is what we really intended these electronic health records to do, which was improving patient safety. So anytime you leverage electronic health record or health information technology to identify or prevent safety concerns before they can harm the patient, that would be in domain 3. We need to be able to ensure that we achieve patient safety by addressing all three domains: safe electronic health record, safe use of electronic health record, and using electronic health records to improve safety. All of these three things combined constitute EHR safety. Next slide, please. So why do we need safer guides? Safer guides are essentially risk assessment tools. They are a list of best practices in the form of a checklist, which we in patient safety use quite a bit of, that can be used for organizational proactive risk assessment. They were initially released in 2014. They were then revised in 2016, but in 2024, we have revised the safer guides because, as you can imagine, a lot has changed with electronic health records and technology. These guides are essentially focused on high-risk areas, and we're going to show you subsequently. All these guides are freely available. Next slide. And just hot off the press, these were just released. The 2025 safer guides were just released yesterday, and they are available freely on this healthit.gov website. The composition of these guides is their foundational guides, which I think everybody should look at. Clinicians specifically will find the high priority practices guide very useful because a lot of those practices are derived from other guides and they're very relevant for physicians. Then there is a guide for organizational responsibilities, which anybody who works in a health system, leadership, whether you're a CMIO, anytime you work in health system implementing electronic health records, you'll find the organizational responsibilities guide very useful. There's two guides that are a bit more technical, so we call them infrastructure guides. One is on system management and the other is contingency planning. And then there's these clinical process guides, which address a lot of those high-risk areas that I was talking about earlier. Patient ID, CPOE, which goes into all kinds of order entry and decision support issues. There's one on test results reporting and follow-up issues. And then there's one on clinical communication, including things like referrals. Next slide. I'm going to hand over to Dean Sittig for walking you through the introduction for safer guides. Thanks.
Thanks so much, Hardeep. As he's just indicated, our next speaker is Dr. Dean Sittig, Professor Emeritus in the Clinical and Health Informatics section of the University of Texas Health Science Center in Houston. Dean received his Ph.D. in medical informatics from the University of Utah and has long-standing research interests that center on the design, the development, implementation, and evaluation of all aspects of clinical information and communication systems, with a special emphasis on electronic health records and clinical decision support. Now, Many of you know Dean has taught and inspired generations of health informaticists, so it really is my pleasure to welcome Dean to give insight on the 2025 edition and to describe the process for updating this patient safety classic. Dean?
Thank you so much, David. It's great to be here and to see so many people interested in the safer guides. The first slide we're going to talk about today is what Hardeep mentioned, is this idea of a checklist. And so we made the safer guides in this, much like many of the different safety tools that have been developed, as like a checklist. And so the idea is you can read the recommendation, like on the left here on 1.1, you can read this recommendation, and then on the right, you can check your implementation status of how you're doing in your organization. Maybe it's like other worksheets, I'm not sure, but it turns out if we go to the next slide, it turns out that a lot of the times when people just read the recommendation by itself, they're really not sure exactly what it means, why we're doing it, or how you would do something like that. So if we go to the next slide, each of these recommendations has its own page in the safer guides that is what we call the worksheet. And on the worksheet, we allow you to give you more details. And so if we go to the next slide, we see that we start with reiteration of the recommended practice at the top. If we go to the next slide, well, then we have a rationale. And if we go to the next slide, we can maybe see that a little bigger. And the rationale is to try to help you to quickly understand what problem we were trying to solve when we made the recommendation. So this should sort of give you a little idea about what we're trying to get into. It turns out that, as you'll see when Patty starts talking, that while it seems so straightforward when we're sitting in our offices, reading the literature, talking to our friends about how these EHRs ought to be configured and how they are to be made so safely. It turns out when you get a group of multidisciplinary people in your hospital together, there's a lot of disagreement about exactly what this recommendation means and whether your organization's doing it. And so we think that this rationale helps a little bit. If we go to the next slide, we can see this implementation status. And we go to the next slide, we can see that you have a choices here of deciding whether you say this is not implemented, if you're making some progress, sort of halfway there, making a little more progress, or if you're fully implemented. This is one of the new parts of the safer guides. This in the 2025 edition, we previously had only 3 sections, and it turned out that those weren't very useful because most people had sort of started their work, their journey along the safer guides, but they weren't really fully implemented. And so they didn't really have much to say other than they were like partially implemented. And then when it came time to sort of figure out what you were going to do with all of this work, it was hard to prioritize your work. So if we go to the next slide, we also show the suggested sources of input on the worksheet. And these are the people that we think you need to have, especially in the room, to help with this particular recommendation. So in this case, we're saying there's people like clinicians and support staff, maybe someone that knows about the EHR and the developer. If you're a small organization, you might want to actually have your developer. There's also some EHR vendors that have developed their own versions of the safer guides that can really help an organization sort of see how to actually configure their EHR to meet that recommendation, and then some support staff. We could go to the next slide. We also have a new part in this version of the safer guide we call the strength of the recommendation. And this is trying to help organizations understand just how important or how much evidence there is, scientific evidence behind each of the recommendations. And I'll go into that in more detail in a second. If we have the next slide. And so these evidence levels, you may be familiar with things like the Cochrane collaboration or other organizations like that that have tried to make guidelines in different areas of medicine. And so there's sort of a hierarchy in terms of how much you should trust your literature. And so usually they talk about randomized controlled clinical trials as being the highest form of evidence. And as we were working through the safer guides, we recognized that we don't have very much randomized clinical trials of various safer guide recommendations. There are a few, especially in the patient ID guide, thanks to Jason Edelman, who is one of the developers of that work, really helped us a lot with that guide this year. And there are some nice randomized trials that he's conducted in that area. What we did realize is that also there's a lot of these recommendations which are sort of required by rules or regulations. Different parts of the government, like HIPAA might require it, or CMS might require it, or maybe your state or federal other state or federal regulations could require it. And so we mentioned those whenever we recognized that these are things that you really need to do, not just because they say it in the safer guides, but for other reasons. And then there's some medium practice level evidence, and this is more like there's been reports of adverse events that have happened because of people failing to do these sorts of things. And then we made a low level just to make it more complete, but we don't have any recommendations that have a low level of evidence in this version of the safer guides. Next slide, please. And next slide, we're going to go to the implementation guidance. Next slide. And so for each of the recommendations, we came up with some different sort of examples of things that you could do to meet that recommendation. So for example, we say you should have a backup. And so this sort of says you should have a daily offsite complete encrypted backup of your patient data. And so this makes it a little more specific. And we also use this implementation guidance to help us set the implementation status, and you'll see that in a second of how we tried to work on that. And so this implementation guidance, you should go through each of those and think about, is this what we're doing? Have we backed up the data as close to real time as possible, or are we doing like an end of day backup, or worse, like an end of week backup? And so you remember with your backups, the time between your backups is the amount of data you're willing to lose, because when your system breaks, it doesn't know whether you've just backed up or you haven't backed up for a while. So you want to back up as close to real time as possible. So if we go to the next slide. So in this 2025 edition, we've made significant changes. We had a lot of expert input on the first versions of the guides, and this time we expanded our expert input. So we have a lot of people from clinical medicine and patient safety, different informatics people, quality improvement, risk management, human factors, people like that. And Patty's going to talk about how you want to have a multidisciplinary team when you're evaluating your safer guides as well. And so it turns out that knowing each of the recommendations in the safer guide is a lifetime of work in any particular area. And so it's very rare when you see people that know clinical medicine and safety and informatics. So you want to get together a really good, high quality team to help you. And we did that when we were making these guides. We also realized, as Hardeep mentioned, that there's been a lot of changes since 2014 when we put out the first version of the guides, and in 2016 when we updated them. There's a lot of new areas. There's a lot more work on patient-clinician communication, patient access to their notes and test results, thanks to the 21st Century Cures Act. There's been a lot of work on AI in the last 2 or 3 years. Cybersecurity has become a focal point of both healthcare systems and the governments. And there's a lot of new software testing practices that have been put in place. And rather than make new guides for each of those, we decided to try to force those new recommendations into the existing guides. And so we've done that to the best of our abilities. And when we were updating these, some of our key principles that we were going on was we were trying to eliminate or combine or clarify different recommendations. So we've gotten a lot of feedback over the years from different organizations that have done these things. And so we hope that we've made the guides easier to understand and easier to follow. And like I said, we've had a lot of feedback from both people like Patty that have been implementing these guides at organizations across the country, as well as a lot of research that's gone on. Next slide, please. And so just as a way of comparison, in 2016 or 2014 was when we put out the original guides. There were 8 guides, individual guides, and then there was a high priority guide that sort of took the best things from each of the guides. This version, there's only 7 individual guides. As Hardeep mentioned, we combined the system configuration and system interface guide to a system management guide. And then we made the high priority guide more focused on clinicians, because that's the one the clinicians have to review to make sure they're getting their CMS credit. We reduced the total number of recommendations from 147 down to 88. So we streamlined the guides considerably. And then the implementation examples, we also reduced those a little bit, but we still have over 500 different examples. And so there's a lot of work to do in these guides. Patty's going to go into that in just a second. The focus on the guides is really on sort of the updated evidence and the stakeholder experience. And the alignment with the policies and procedures are really designed to meet the current regulatory and clinical needs. So if we go to the next slide. So I'll give you one example of a new recommendation that we've put in. This is the artificial intelligence recommendation. And we did this to try to help people to understand, and there's an entire paper on this in a recent version of JAMA, and I think this will be available from AHRQ after this webinar. And so this is basically, we're trying to tell people that, you know, you're going to have to do your own clinical evaluations, and if you can't do your own, you should review real world clinical evaluations. And you know, you'd be hard pressed, I think, to be using AI that has not been clinically evaluated. And that's been a weakness of a lot of the clinical systems we've been putting in place recently. I think you should do some real world clinical testing at your organization, because it turns out your local data systems may be different than the way the system was trained on. You may have different data definitions. And so the systems may not work the same in your organization as they work in other organizations. And then you always have to be doing iterative risk-based assessments on these things. So just like people, AI can get out of date, it can start a slip in its abilities, and it can do what they call drift. And so sometimes the systems don't continue working at the same high level that they started working on. And I've already mentioned the importance of a high-level multidisciplinary committee for your safer guides. When you add AI governance in, you want to add some AI experts to those teams. And that's hard to find in small healthcare organizations. In larger ones, you can probably find some people like that, but you might want to bring some outside people in to help with that. Next slide. We also have some more things about making sure that your clinicians are trained in how to use these systems. While it seems like they're pretty easy, it turns out that knowing how to use the AI systems helps them work a lot better. And so it's just like any other tool. The better you are at using your tool, the better results you'll get. And we think there ought to also be consent, both for the clinicians should be consenting that they're willing to use the AI to help them in their practice, as well as the patients to consent to be treated with these AI systems. And so in addition to training the clinicians, we also think you really need to train the patients about how these systems were developed and used and how they're being overseen in your organization. This is really a brand new field. We're right at the beginning of this, and we have to really be careful with these AI systems. I think that every AI generated recommendation should have a human review before it's seen by the patients. I know this is a particularly sticky situation because we're trying to use the AI to improve the efficiency and effectiveness of your organization, but there's still a lot of reports of AI making mistakes. And so if you just saw that Apple had to take away their news, automatically AI generated news feeds because they were making mistakes in their news feeds with their AI systems. And so they're still making mistakes that we don't quite understand why and how. We think there ought to be a lot of reporting mechanisms, because just like with EHRs, there's going to be problems with these. We need to be able to report these. Your clinicians need to know how to do that, and your patients need to know how to do that. And then I talked about a multidisciplinary team. You also need a process to analyze and address these reported safety concerns, because this is a whole new ballgame, as I mentioned, and it's difficult to understand what's going on, why these systems aren't working the way we anticipated. If I go to the next slide. And so Patty's going to go on and talk about this 5-step process that we developed a few years ago and published that in JAMA as well, about how you should go over these safer guides and what you should do with your organization. And if we go to the next slide, I think it's time for Patty to start talking. Thank you very much.
Yes, thanks, Dean. I think that was fantastic. You know, the credo of safety engineering is theory and practice. The practical application of your design makes all the difference. And in that regard, we are really, really fortunate to have Dr. Patricia Sengstack with us to discuss the hands-on use and practical considerations for healthcare systems employing the safer guides. Now, Patty has been a Senior Associate Dean for Informatics at Vanderbilt University of Nursing. She's been the Chief Nursing Informatics Officer for the Bon Secours Health System and the Chief Clinical Informaticist at the National Institutes of Health Clinical Center in Bethesda. She's the past president of the American Nursing Informatics Association and has been inducted as a fellow into both the American Academy of Nursing and the American College of Medical Informatics. Her focus over the last several years has been the impact of health information technology on patient safety, as well as work to reduce the documentation burden in the electronic record, which is why she is the perfect person to sort of finish up our discussion of using the SAFER guides today. Patty?
Dr. Hunt, thank you for making me sound so important. So thank you for the introduction. It's an honor to be part of today's webinar. I've been asked to join today to share an example of how an organization has implemented and operationalized a review of the SAFER guides. So as he's mentioned, as Dr. Hunt has mentioned, I've been doing this and leading this effort for several years at a couple of different organizations, most recently at the Vanderbilt University Medical Center. And so I will share with you some highlights of our processes, and then at the end, can take any questions during the Q&A session. So to get started, one of the things that was really important to our team was, one of the things they talked about quite a bit was, we don't have time for this. And I'm sure a lot of you listening can feel the same way. We don't have time for this. There's a lot of recommendations, and we don't want any more meetings. That was kind of the mantra that we've had. No, please, please, no more meetings. So what we had, fortunately, was already in place a bi-weekly health IT clinical director meeting. So we had a group of health IT clinical directors, and this is a diverse group of stakeholders. We had practicing physicians, physician informaticists, nurse informaticists, pharmacy informaticists, researchers, informatics researchers. So we had this core group already in place, already meeting every other week. So we thought, let's use this time to do it. So we did, and we carved out a period of time on each agenda to talk about the SAFER guides. So you can imagine that we didn't do it in one fell swoop. We really did it over a period of months. And so we, I estimate that we reviewed 2 guides in a given month. So each guide at these meetings were introduced and we talked about it. This was all synchronous. And as we talked about each of the guides, we had to determine if we needed somebody else at the table. So do we need somebody from cybersecurity? Do we need somebody from quality here? And so we made sure that we had the right people at the table when we were having these synchronous discussions. Next slide, please. So after we had these sort of initial discussions, we would transition to a more asynchronous approach. And we were fortunate to have a program manager to help us out to do this, because we realized that at the meetings that we had, it was a piece of the agenda. It wasn't the entire agenda. So we thought, why don't we do the follow-up deeper dive by surveying all of our stakeholders by using let's survey them. And so we created an electronic survey that had that checklist that Dean showed you of the SAFER guides. And we had that wonderful program manager to manage the logistics around distributing the survey. And then and a little bit more about the survey in just a minute, but it was great having a program manager, somebody assigned to do this, to help nudge everybody that said, hey, can you go ahead and finish up the review of the survey for a particular guide. And then the program manager summarized the data and created a report. We did one at a time. We did one survey, one guide at a time. And part of that included looking at the worksheet. So Dr. Sittig shared with you the worksheet that had all kinds of great information in it on examples of how other organizations have met the requirements for the recommendation. And so we had them look at the worksheet. We sent the survey out. We did it one at a time. We did it over several months. We started this in March of 2022, so that was the first year that we had to attest. We've done it subsequently. We've done it in 23 and 24. I'll talk more about that in a little bit, but if you could go to the next slide, please. So again, a survey, we created a survey for each guide. It was sent out, and then the respondents were asked to rate each recommendation using one of the following choices. Now, you've seen these have changed, and I'm very happy to see that, because that partial response was sometimes problematic. So they had to, on this, and I'll show you an example of what the survey looked like, but they had to select fully, partially, or not implemented. What we were seeing was that with the partial, sometimes somebody would say, well, we've started it and we're like 20%, or we're like at 90%. And people were, maybe a little afraid to say, yeah, we've got it fully implemented. So they'd say, well, we got it 90%. But they would have to say, okay, we've got it partial, and we wouldn't really know or understand if we needed some focused attention based on just that one choice of partial. So I'll show you how we tackled that in just a second. Also, you could put comments in this survey as well if you wanted to put some notes in there. So next slide, please. So here's just an example, and you'll see, this will we use red cap. And so you had the recommendation, and then you could choose from fully, partially, or we actually gave people an out. If they felt like this is not my area of expertise, I'm not an expert, they could choose that last radio button, place to put comments. And then I know this is a little bit tricky to see, but at the bottom, if they chose partial, there's a little indicator, it's a slide bar that they could slide up and down that went from 100% to 0. And they could choose the percentage of partiality that they believed that particular recommendation had been implemented at. So this is what each of the questions look like. And if you go to the next slide, I think I have some kind of results of how we did here. So this is a snippet from our report. And this is, remember, this is from 2022 when we did this the first time. This is 3 of the recommendations that were from the system configuration guide. And you can see that all of the respondents all said, we got it, we're good, we're fully implemented in all areas. If you go to the next slide, that's not actually what we saw most of the time. Most of the time we would see kind of a mixed bag. We would see some people say fully, yep, we got that. And then we would see some people say, we've got it, but we don't have it all the way. And here's where the slider really helped us, is that in determining the percentage of partiality, you can see that in this particular example, let's see, 83%, had to get close to see that. 83% average was the partiality. So that's really pretty good. If you go to the next slide, you can see that most of the time, as I said, when we got the responses back, and this is the data from all 147 different recommendations, you can see that most of the time, 119 to be exact, some people said fully for a recommendation as well as partial. You can also see that 39 times every single stakeholder would say we've got it fully. So that was good news. We also saw that, we were happy to see that not implemented, we did not have one recommendation where everybody said, we don't have that at all. You do see, however, that there are a few in there where maybe 1 or 2 respondents did say that we didn't have it at all. And that certainly is an area that, we've been putting some focus on. So if you go to the next slide. Other way. One more. Okay. So first we wanted to identify, as we looked at the results of the survey, we wanted to identify any recommendations where the respondents indicated that we don't have that, we've not implemented it. And as you noted, we had a few of those. So we wanted to take a peek at those. Or we wanted to look at any recommendation where they indicated that less than or equal to 50%, they felt that, perceived that it was partially implemented, but at 50% or lower. So those recommendations we had, there were 3 of them that we identified in the area of contingency planning, mostly around downtime preparation, which is probably no surprise to most. The CPOE, we had 3 recommendations, and then clinical communication, we had 1 recommendation. So those 3 were the ones that we paid a little bit more attention to and tried to figure out if we needed to put a group together to take a look at these areas. So if you go to the next slide. So as we did each of these surveys, we would get the results back and we would see those discrepancies or differing opinions. You know, somebody would say we've got it and somebody would say no, we don't. So we're going back to the synchronous of these meetings that we already had in place. We would look at the results and we would say, okay, let's talk about this. And sometimes people just didn't know that we already have that in place, or at least we have it partially in place. So those synchronous discussions would occur again after we got the results back. And so then we could figure out if it was something that we really needed to pay attention to. So at these synchronous meetings, we determined, like, where do we need to focus attention? What are our priorities for the next year? Of course, we had to present our findings to leadership, and then with some recommendations and opportunities. And then, you know, we would start to think about next year. How are we going to do this next year? Now, in subsequent years, I'll just share that we did not use the survey methodology in calendar year 2023 or 2024, because what we did was we took the results from 2022 and we utilized those areas of vulnerability or areas where we had work to do and just continued our work in that area. So while we would do just kind of a brief review of all the guides again, I mean, we went through all of the recommendations, but again, we just focused on those areas where our survey indicated that we needed some help. So now, I guess, you know, I'm sitting here thinking as Dean's talking about the new 2025 revised version and the new ways to, I love that we now can choose different levels of implementation. And I'm thinking, you know, we're having discussions now as to whether or not maybe we should do the survey again this year to just kind of get that baseline of where our areas are. So if you go to the next slide, I think I'm wrapping up at that point, and we'll say thank you for listening. And I think I turn it back over to Dr. Hunt.
Yes, thank you so much, Patty. That was wonderful. As Patty said, right now we're going to open up the discussion by taking a few questions. And while we take those questions, I'd like you all to tell us or to think about how your organization is going to be using the guides in 2025. I think it's going to be important, again, that we all have a plan on how to do this. And if it's okay, we have all of our panelists come on screen. I want to highlight a few of the questions that we've had, make also a couple of comments. First, I want everyone to note that the slides in the recording will be posted on the National Action Alliance webpage after this session and will be sent out to attendees. So you'll all get a copy of these slides, and you'll also be able to refer back to that recording. The next question is interesting and is good, and I appreciate it so much. And that is there a plan to update these on a more regular basis now that as part of the CMS quality payment program? I can say that my sincere hope is that we will. I can't promise anything right now, but I think that at ASTP, we've really come to appreciate the value of these guides and how important they are throughout the entire health IT community. So our hope is that we will be able to update these on a more regular basis. And I think that'll be made a little bit easier. I do have a couple of, one important announcement, or two actually announcements. First is that the new guides, as you've seen already, are available. You can take a look at them on the website, as well as the current set of guides or the older guides that are currently used for the quality payment program. But also a little bit later on in the year, we're going to be able to make available a database that is it can be used as a companion to the guides. This is a relational database that will make available to folks to download and to use, in which they'll be able to see all of the recommendations sorted and such that they can sort, search, navigate through them a little bit easier. One thing that's very important for me to make sure that you understand, this is not a database that will record your answers, okay? So this isn't a collection activity. It's really seen as another way, another medium that will be able to get this information out, get these recommendations out to people, and perhaps have some of the more sophisticated health systems be able to use a database to incorporate it a little bit easier into some of their programs. And finally, I want to answer one of the questions that I saw here to ask whether these guides were updated to align with the new HIPAA proposed rule or vice versa. No, they haven't been. But one thing that has been asked before of us at ASTP, and I think we're going to take this under a very serious advisement, is to more explicitly see where we can have the opportunity to draw bright lines of crosswalk between the guide recommendations and other activities that you may be doing, individual providers as well as hospitals may be doing or required to do, such as the security risk assessment tool, the HIPAA guidelines, to make this entire process a little bit easier for those that are doing multiple things. Wow, I'm seeing a lot of questions here, and I want to thank Jeff Gold for posting a relatively new article in Nature. You'll all see the link to that discusses how large language models for medical systems might be vulnerable to some other influences and attacks, actually. So let me actually go back up now that I've gone through those guides. I'm going to say, look at some of the questions. Will there be a document indicating the changes for the guides? I think that you'll be able to see those changes a little bit more easily once you begin to dive into the guides. And Amanda indicates that we conducted a survey similar to the presenter, nearly identical, but also added in the responders' original response so they could indicate if there have been any changes from the year prior. I think that is a very, very good recommendation. Yeah. Now, I'm sorry, someone was going to jump in. I was just going to say there was one question, and I'll open it up to the group a little bit more, is that there's a question about whether or not there'll be any recommendations or tips, specifically how small and independent practices might be able to implement the guides successfully. Steph goes on to say that many do not have time to take away from patient care, the expertise, or the financial ability to do it as thoroughly as some hospital systems might be able to do it, and they're asking for help on how to do this. I'm going to start off with the answer to that because I'm in a small 2-doc surgical practice, and I will have to admit that going through the guides were a challenge. It was very difficult to, again, take the time to go through them. The thing that we found out with the guides, though, is that it is very helpful and very insightful to see a little bit deeper and dive a little bit deeper in how your information system actually articulates with your practice. So that is to say, this is going through those recommendations isn't a one-off or something that can only be used to check the box for an attestation. It gives you real intimate and very useful knowledge on your practice. And if someone were going to ask, would you like to have a checklist on to see how your practice works or utilizes health IT a bit better? I think many of us would say yes. The key to going through the guides in a small practice is the way you eat an elephant. That is to say, small bites, one little bit at a time, and to go through those. Make sure that you have your team there to together in a small practice. That'll probably be the practice manager, the providers, maybe a nurse or two, and also, if you have an implementer or someone who helped you install that EHR, to maybe have them on hand and just one by one go through those guides. The high priorities guide was specifically designed for the use of clinicians at the pointy tip of the spear, if you will. So I'd recommend that you start with that. But I would not be surprised if you'll find, as we did, that you want to dive a little bit deeper into some of the other recommendations too, once you're able to complete the guides. Let me stop talking here and see if some of our other panelists have any other recommendations along those lines.
David, I can add that for a smaller practice, and I think the same rule applies to hospitals as well, because some of the hospitals are also strapped for resources and time. It would be also important, as somebody already mentioned, that bringing the guides into routine committees. So you may have some sort of a clinical practice, meeting. People have morbidity mortality meetings. People have all kinds of medical staff meetings where you discuss clinical issues. And there are safety issues happening. I mean, people have lost test results. I mean, smaller practices have lost test results. It would be a great idea to sort of integrate the discussion of some of these practices when real events, safety events happen, and there's already an ongoing discussion between multiple people how to improve safety and how to reduce those events in the future. It would be a great time to bring in safer guides discussion.
Thank you. I've seen another question, and I appreciate Lorraine, who posted the question. It might have been just before I had made the announcement about the database, but she asked, will the safer guides come in a different format like Excel in addition to what is available on the website? And I mentioned that, yes, we're going to have the safer guides available in actually a Microsoft Access database. Microsoft Access is included in many, if not most, if not all, Office implementations, and it does take a little bit more sophistication to actually use, but it is incredibly helpful. One of the things I'd like to lead at ASTP is to see if we can implement a project that helps people perhaps use that Access database approach with an interactive website, or to help guide other organizations to help make an interactive website as far as the guides are concerned. Because one of the reasons I really look forward to the opportunity to get this new addition into a database is, one of the things I said is, wouldn't it be wonderful if we could see what recommendations, say, the pharmacists are responsible for, what recommendations are really all targeted for the clinicians or in the leadership positions. All of these different input sources are now available in the 2025 version of the guides. And I think the ability to sort, search, and to navigate all of the recommendations with the database will make that a little bit easier. In addition, you'll notice that there are keywords that are going to be able to be searchable with the guides to make it actually a little bit easier in that regard. So thank you, Lorraine, for asking about having the guides in a different format. I highly recommend it. One thing that came up, we had a wonderful session on the guides back at I guess it was December in the ASTP annual meeting. And one question that came up was, for hospitals, you know, every year we go through the guides and we have to additionally do maybe another HIPAA compliance or security risk assessment tool, and navigating all of this would be difficult. And one of the suggestions that came out was, well, you know, if you have the recommendations in a spreadsheet, you can revisit those a little bit quicker, a little bit easier. And the hallmark to good business practices is to have an insight into what's coming up around the corner and the next week, the next month, the next year. Having them in a database such that you'll be able, or an Excel spreadsheet, such that you'll be able to parse these recommendations out to the individual interest holders and equity holders within your organization to continue to look at these as things change over the year, I think will be a great opportunity for everyone. Let me see, are there any other questions?
I was going to say, I would like to add to David's comment there, is that several of the EHR vendors have developed their own versions of what I'll call the safer guides, where they take each safer guide recommendation and then they say, this is how you would configure the EHR to meet this recommendation. So I know that Epic and Meditech and eClinicalWorks and Cerner have all gone through that kind of I guess Oracle have gone through that kind of an exercise already. So in a lot of cases, you can sort of lean on your vendor to make sure your EHR is configured. Now, there's always things that your organization has to do as well. Like, just because Epic has a backup facility in place doesn't mean that you have dedicated the servers to store those. And so you always have some responsibility as well, but your vendors are going to help you a little bit.
And I see there's a question from Anne, and this comes up quite regularly, that asks, will the recommendations eventually be required to be fully implemented? Well, first, let me make sure that you understand that the safer guides have been incorporated into the CMS quality payment program as part of their safety portfolio. And they simply ask that you attest to that you've gone through the guides. For individual Part B providers, they ask that you go through the high priorities guide. For hospitals and hospital systems, that you should use all the guides. And I can say that I've never heard of, or I don't know of any plans or suggestions that they be scored to such that they be required to be fully implemented. You know, one big aspect of safety in general is that it is a environment in which you are free to get back with feedback as far as what things are being able to you've been able to do and what things you're having challenges with. And I think that in some aspects, having a requirement to fully implement every single aspect might be in some ways counterproductive, because and let me ask the authors, I know that in some instances, you can see a situation where it will be very difficult to completely implement some of the recommendations, but that doesn't mean that a partial implementation in a specific circumstance doesn't significantly improve your safety posture. Dean, Hardeep, or Patty, any thoughts as far as that's concerned?
I'll let Hardeep take that.
And then I want to add something when Hardeep is done, okay?
You go first.
Yeah.
Well, what I wanted to say was, you know, because Dean and Hardeep have been so kind to bring me along on this journey with them over the last several years, and my name shows up on some of the, you know, publications because I get to add my 2 cents. People will call me and ask me questions. And so one of the questions that I get asked all the time is, not only do we have to meet these recommendations fully eventually, and from what I've heard again and again, the answer is no. But we would like to see progress, you know, but I have no idea if that's ever going to be enforced in any way, shape, or form. I get the sense that the review of them is the most important thing, because then the organization knows where you have vulnerable areas and you're going to focus some attention on there. The one thing that they asked me a lot of, and I've mentioned this to Dean and Hardeep before, is that people say all those examples that you provide in the worksheets, there's several examples, and so they asked me if those are those things we have to do too. And I know that the answer to that is no. It's because everybody's going to do this a little bit differently. Everybody's organization is different. So how you implement it is going to be different. How you operationalize it. Those are there to be really good examples of how other organizations have met that. And I think they're important to take a look at, but important to know that you do not have to, add that as a recommendation. And Dean and Hardeep, I don't know, we've talked about this before. Do you want to say anything else about that?
I'll start. So I'll start by responding to your sort of example sort of question, then I'll try to answer the original point here. So I consider those best practices that we recommend, the recommendations, as something like you should eat fruit. And I consider the examples as, oh, here are the different types of fruit you can eat. You can eat bananas, you can eat apples, oranges, whatever you feel, and whatever you like. So I think people should focus more on recommendations rather than examples, because examples are just ideas of what you can do in your organization. The second thing I want to emphasize, I think people should think of these guides as not so much as a stick, which I'm seeing a lot of the comments as if perception is like, you making us do this, we have to follow laws. No, these guides are mostly about improving patient safety. If you look at the sort of the recommendations, as David already pointed out, it's basically attestation. As Patty pointed out, did you review the guides to see if you could do better? There's no absolute stick coming if you mark, less implemented and more implemented on the other. I mean, there's nobody sort of coming down to sort of check on every single answer, not yet that we know of. And maybe CMS could comment and make the rules different in 5 or 10 years. But I would think that folks should consider these as risk assessment tools, patient safety improvement tools, talk to your patient safety people, find out the types of events they are having, figure out how you can work together with them on addressing some of these, recommendations. So that would be sort of my biggest sort of take, that I don't consider this a big stick. I consider these as, here's some guidance on how you can improve patient safety.
Yeah, I was going to say that, when we started this process, we always thought of this as sort of a way to sort of level the playing field, or, start a conversation. So I've been in a lot of organizations where clinicians will say something like, I think we ought to have a better, we've had some patient identification issues in our organization. And, I think the EHR ought to be a little different. And sometimes the IT people will push back and say, no, we can't do that. And so we use the SAFER guides. And the idea is, it says right here in the SAFER guides that we should have, if there's two names that are close together, we should, recognize that and tell someone that. And it says, and the clinician can say, it says right here in the SAFER guide that we should be able to do that. And then you tell your IT department, we really need to do this. And because, there's not an equal amount of knowledge between how the EHR works between clinicians and IT people. And so we see the SAFER guides as sort of trying to give the clinicians just a little more confidence to push back on the IT people when they're saying something. And so, like Hardeep said, we're trying to improve patient care, and I don't think anyone's against that. And I think a discussion is what you want to have. And then people start saying, well, you mean we're not backing up our system? I think if a clinician found out they weren't backing up their system and that they could lose all their patient data or all their bills for the last week, they would tell their IT people, I don't think that's the way we should run this organization. And I think that's the way you should think about this, and not think about it as, heavy-handed government oversight or anything like that. These are very, very basic things that are, for the most part, we ought to train people before we make them use the system. We ought to back up our systems. We ought to make sure that someone got the communication that we sent to them. These are things that are not controversial at all.
I agree completely. And I think that we can sort of summarize this whole discussion. There have been some wonderful questions that have come through, but I feel comfortable summarizing some of the key takeaways today, namely that one, safety is a journey. And while health IT safety is complex, but an essential undertaking, and the updated safer guides can make that process just a little bit easier. And you all know that CMS has been including the guides as part of the quality payment program for some time, and I think it's definitely been a help and improvement throughout the communities. Next slide, please. I think that I want to make sure that everyone understands that this is the first of webinar of this series for the year, and we welcome everyone to join us over the next few months for next month's webinar on February 18th at noon, where we're going to be able to focus on psychological safety. That'll be a deep dive into the role and impact of psychological safety in establishing a safety culture. And I think that's a wonderful place to use as a jumping off point for today. I want to thank all of you for joining us, and I hope that you're able to I wish you all the best, and I hope you're able to stay safe out there. Take care.
Thank you, everybody.